All right, thank you very much. I think we should start. And I'm hoping that as we start, people will come join us. And I'm starting this session by saying, my name is Boniface Ushie. I work for the African Population and Health Research Center in Nairobi, Kenya. I was supposed to be seated at sitting there and following the presentations, but one of the presenters was also the facilitator. So I'm standing in for him. And I also want to mention that, as you can see, almost everyone is wearing a face mask. This is something that came upon us in 2019, late 2019. It did not just force us to be wearing face masks. It also has several implications for our world. And it is for that reason that we are sitting in this room today. So the session that will be happening in this room is multi-country examination of the impact of COVID-19 on family planning. Now, there are 4 presenters that will take us through this session. Each presenter will have 15 minutes to talk to us, and then we use the rest of the time to ask questions for clarification, and any other, maybe you have comments, you keep your comments when they've presented, we can ask our questions. But please do engage. I know that the room is still building up. As they are presenting, write your questions and do engage so that there will be feedback for the presenters to take and develop their ideas and their papers into something meaningful. All right? Now, allow me to to introduce the first person. He is Jerry Sparks. And pardon me if I pronounce your name in the way that is not meant to be pronounced. And if I have not mastered your title, like maybe professor, doctor, is very impromptu for me. So the first person I'm introducing is Jerry Parks. Jerry, your affiliation is Avenir Health. So Jerry is from the Avenir Health, and he will be presenting to us on the impact of COVID on family planning programs in 15 low and middle income countries. So Jerry?
Thank you.
Yeah?
I don't have any titles, so there are no titles to get wrong.
All right. I thought I should call your names before. Just give me a second. Let me call everyone's then. And then the second person, Ramatu, are you ready? I'd like you to sit with Jerry up here. Yeah. So this is Ramatu Daruda. She is a family planning policy advisor with UNFPA, East and Southern African Regional Office in Johannesburg. The third presenter, and they will be presenting in that order that I'm calling the names. The third presenter is Karen Hardy. She is the president and CEO of What Works Association. Hello, Hardy. All right. And then the final presenter will be Kenneth Juma. He is a research officer at the African Population and Health Research Center. That's the same place that I work. Kenneth, thank you. We will be happy to listen to you all. Now, Jerry, over to you. 15 minutes.
Great. Thank you so much, Boniface. I should use the microphone so that the camera can record, right? Okay. All right. Good afternoon, everyone. Thank you for being here. I know it's late in the day on the first day of a very busy conference. So my name is Jerry Parks. I work for Avenir Health, and very specifically, I work for the Track 20 project inside Avenir Health. Track 20 is dedicated to improving data quality across countries, specifically in the family planning 2030 commitment-making countries. So we work very closely with them in terms of monitoring the data and the indicators produced each year by those countries, and then also improving data quality in those countries. So today I'm excited to talk about sort of a side activity that we were able to put together over the last few months, which is using family planning service statistics, normally from DHIS2 or similar programs, to evaluate the impact of COVID-19 across 15 low and lower middle income countries. So this is a very large slide with a lot of names on it, and I'm sharing this just to emphasize this was a very large undertaking, and we had a lot of support from many different countries. This involved getting data sharing agreements from the 15 countries, asking them questions about what is inside their DHIS2 or other HMIS system, and then repeatedly bothering them with more questions and follow-up questions to figure out strange things in the data. So we are extraordinarily grateful to everyone who assisted with this project. The fact that we had so many countries, I think, speaks to our good relationship with many of the Track 20 countries that we partner with, and also how passionate that everyone is about sort of measuring the impact of COVID. So we all know that COVID had a very large impact across the world in a variety of areas, and I think there was a lot of fear that the pandemic would really derail family planning programs around the world. We had actually, at Track 20, we had actually worked on an analysis of the Ebola outbreak and how that had impacted the family planning programs in Liberia, Sierra Leone, and Guinea. And because of that, we thought we were well positioned to do a larger analysis of COVID impacts across the 69 Family Planning 2030 countries. So one of the major things that we saw with the Ebola outbreak was that, yes, there was a very large drop in services, very large drop in the amount of family planning products that were being distributed, but there was a very quick return to normalcy after the pandemic. So we were curious if that would be the case with COVID. There were also a variety of different things that would impact, the family planning programs. With the health staff were being diverted from working on family planning to doing contact tracing, doing reporting of cases, things like that. We knew that lockdowns were making travel difficult, and especially for staff, which was a major piece. We knew that women were staying away from clinics due to a fear of exposure. We knew that a lot of the factories that produce, the generic condoms and implants, injectables that countries around the world rely on, those were based in Asia. And of course, they were suffering from lockdowns and employment shortages and things like that. And of course, the side effect of that then would be delays of shipments and transportation of things of various methods. And all of that would factor into a fear that women would either stop using methods or switch to something less effective, like a traditional method that was more readily available. So these were sort of our fears and our worries going into the research. We started this activity at the end of 2021, and by the time we had begun to undertake this activity, there was some literature out there about early findings on COVID impacts. So we did see a few studies from South Africa, from Chile and Nepal, and other places that showed that there was a pretty radical reduction in services during those lockdown periods in March, April, May 2020. I have data here from IPPF, worldwide closures, very specific data from South Africa. But we also saw some data that was a little odd in that it wasn't showing a massive change compared to previous years or pre-COVID. So it was sort of a mixture, and it seemed to be very localized to those first few months of lockdown. So this was the premise under which we were operating when we went to actually do our research. So these are the three questions that we wanted to ask to sort of measure impact of COVID-19. So the first one is did family planning use actually increase between 2019 and 2020, or did it decrease? The second one is, were changes in family planning use driven by changes in long-term methods or in short-term methods? And then very specifically, we wanted to look at implants and injectables because we have really excellent data for them across countries. And what exactly happened with those two methods in 2019 and 2020? So to get started with that, we reached out to our Track 20 partners around the world. We have monitoring and evaluation officers in over 24 countries, And we were lucky enough to get permission from 15 of those countries to actually look at their service statistics data in close detail. So I have the map here with the list of countries, but what I think is important to note is that this was a pretty wide range of geographies. This was a wide range of health and level of development of family planning programs. And so we were able to get a pretty wide range of different experiences, right? So I note here that the contraceptive prevalence rate for modern methods, it goes anywhere from 11% to 49% across the different countries. And they all had different political responses to the COVID pandemic. So some had very long, strict lockdowns. Others were more relaxed about it. So the major piece of data that we used for this research was service statistics. This is what we refer to as the data found inside a DHIS2 or another health management information system, very specifically related to commodities distributed to clients and also users of family planning services. So Track 20 is very interested in using these service statistics throughout all of our work. And because we have a long history of using service statistics and improving the quality of service statistics in our partner countries, we thought that this was a great way to monitor and assess impacts on a very low level of detail, down to the level of the month even. So on this little colored bar that we have here, this is the list of our member countries who use service statistics. And we have helped these countries get to the point where their service statistics are of a high enough quality to be used in terms of producing annual estimates of family planning indicators. We have a very specific indicator that we use called estimated modern use, or EMU. EMU is a proxy indicator that we developed at Track 20 to serve as a companion to MCPR. It is not an exact correlation, but in theory, an EMU should have the same sort of trend as an MCPR. And the indicator is actually the estimated number of users from DHIS2 divided by the number of women of reproductive age in a country. So this was the major unit of measurement that we used going into our research. And I know I have a lot of countries and a lot of colored bars on this page. And so what I want to show is this is just the 2020 and 2019 EMU for each of our 15 countries that we worked in. And the major thing that you will notice is that the blue lines, which are from 2019, and the green lines from 2020, it's usually the green line that's bare, right? So we actually saw increases in our EMU in 12 of the 15 countries between 2019 and 2020. We actually only saw declines in 3 countries, Nepal, Pakistan, and Togo. The EMU has some built-in assumptions about private and public sector use of family planning. And that basically is there to account for the fact that we do not have access to all types of data from all sectors in our countries. So the data you're seeing here is only from public sector sources. So we expect and we build in the fact that there probably was quite a bit of shifting going on to the private sector as a result of COVID-19. So this is the same graphic, just changed to account for long-term method users versus short-term method users. So the light blue are the short-term method users in a country, and the dark blue are the long-term method users in a country. So in the few countries that had declines in users, all experienced declines in short-term method users. It was only Pakistan that saw declines in both long-term and short-term users. On the other side, we had Mali, Niger, and Uganda. They had declines in short-term methods, but on the flip side, the growth that they had in long-term methods actually offset the declines elsewhere. Madagascar and Zimbabwe were the only 2 that actually had declines in long-term method users, but not short-term methods. So in general, most of the declines we saw were in short-term methods, which makes sense given that in many countries, clinics were closed for 3 months, and things like pills, injectables, emergency contraception, obviously those are needed more regularly and more frequently, and without that access, it's harder to get to them. So in terms of the implants and the injectables, these were the ones that we were particularly interested in because these are methods that are increasing in popularity around the world. They also require face-to-face interactions with health providers, which of course was a huge concern and a huge limiting factor during COVID-19. We do acknowledge that there are some countries that have self-injection, and that number is growing, but right now, statistically, the numbers of self-injection users is quite small. So all 15 countries that we worked in, they actually had injectable and implant use in 2019 and 2020. 12 of those countries actually grew their number of implant users between 2019 and 2020. That's the purple boxes here. And 3 actually had declines. These are the ones in orange. So that would be Madagascar, Pakistan, and Zimbabwe. Pakistan had the largest decline. The estimated number of implant users actually decreased by over 1/3 in 1 year alone. So 9 countries had increases in injectable users and 6 had declines. DRC, Madagascar, and Zimbabwe all increased their estimated number of injectable users by over 20% year on year, while Pakistan had a 38% decline in injectables. So there's some strange bit of information here. You know, we were hoping to see that in countries where there was an increase, it would be an increase with both methods. You know, for example, Democratic Republic of Congo or Uganda, you know, both implants and injectables grew year on year. Pakistan had decreases from 2019 to 2020 in both methods. So I think we're a little confused and very curious about the countries like Cote d'Ivoire, which had a huge growth in implants and a reduction in injectables. Our suspicion in the case of Cote d'Ivoire is that there was actually a lot of shifting going on to the private sector as a result of COVID-19, and that in many countries there were also pilot programs of self-injection that were naturally coming to an end, or not self-injection, of injectables that were coming to an end, you know, at the end of 2019 anyway. 1 minute, okay. So these are basically our results were that Pakistan had the strictest lockdown, and we see that in the impacts on its family planning program. We saw that a lot of health workers were redirected. One of our M&E officers actually quote that they were being stretched thin because of COVID. We saw that some countries had curfews and limitations on transport that limited the ability of staff members and patients to get to clinics. We saw that in some countries, money was reallocated from family planning to cover COVID expenses. And we did see in other countries like Togo that there were, and Cote d'Ivoire, that there were delays in getting shipments. However, on the flip side, we did see a lot of positive outcomes from this. You know, there were countries that worked really hard to send out social media and text campaigns that promoted FP. In Zimbabwe, they actually had the really brilliant idea, or Philippines, excuse me, the brilliant idea of combining food deliveries to people's homes with deliveries of contraception. Places like Kenya really strengthened their community-based distribution. Places like Togo actually increased the amount of short-term methods that they would give at a time to users. So they would give a 9-month supply of pills instead of a 3 months. And a lot of extra time and investment was allocated to health records and data quality to make sure that what people were monitoring during COVID continued and carried on into other health areas. So the very quick takeaway from all this is that the impact of COVID-19 was smaller than expected, and that most countries actually saw improvements from 2019 to 2020, and that family planning programs are very resilient and durable. And I think that speaks a lot to the quality and the hard work of the staff in those programs. So thank you very much.
Thank you very much. Now I will call on Ramatu.
Good afternoon, everyone. Good afternoon. Thank you. My presentation is on multi-country examinations of impact of COVID-19 on family planning in 6 countries in Eastern Southern Africa region. This is just the outline. So a brief background, everyone knows, of course, how COVID-19 emerged and then spread to all continents. We all know about the lockdowns and how it affected access to health services. And so to find out the impact of COVID-19 on family planning services uptake and also last mile assurance, the East and Southern Africa Regional Office supported 6 countries: Burundi, DRC, Kenya, South Sudan, Uganda, and Zambia to conduct a rapid assessment and analysis. This analysis was done individually in each of these countries. First of all, before I continue, I forgot to say, this study was conducted in these 6 countries. I am presenting on behalf of my colleagues in the regional office, Kanyanta Sunkutu, Michael Teki, our consultant, Chris Owanda, and also all the focal points in the 6 countries that I listed who supported this study. The main objectives of this assessment was to see if there were really any changes in uptake of family planning services before, the comparison, and then during the pandemic. And then also to estimate the reproductive health outcomes 3 years before the pandemic, to say between 2017 and 2019, what was the uptake like? And then compare it with Q1 to 3. We needed to do this assessment before the end of 2020 so that we could plan ahead. No one knew how long this pandemic was going to last, to see the effect and then come up with recommendations to ensure that women, girls, and everyone had access to family planning services. Also because UNFPA monitors the effect of, does last mile assurance, making sure that commodities get to the primary healthcare centers, to the hands of the women. We decided also to assess, just using a checklist, just how have the processes been affected. So the methodology was a quasi-experimental pre- and post-assessment of changes in family service utilization and health outcomes that are linked to the emergence of COVID-19. Then there's a trend analysis that is looking at the quarterly changes in selected service utilization and then reproductive health outcome indicators before and after COVID. And then January, of course, to March was what we took as the cutoff point for emergence of COVID-19. And then for the last mile assurance, we usually do this in Q4 assessment and really checking. We didn't have any comparison for previous years, but we just wanted to find out if activities actually happened as they should or if COVID affected them. So this is the data collection method we use. Really, there's just data from DHS2, the LMA plans, and then analysis was done using Maristop's Impact 2 tool, and then DHIS and HMIS data. So, brief background, of course. Each of the countries had completely different administrative settings and responded differently to the epidemic. For example, Kenya has a decentralized government, and counties had different responses. And some areas were designated hotspots. Burundi and Zambia didn't have any lockdowns. So again, response was different. All the countries have a history of public health, emergencies, cholera outbreaks, regular humanitarian crisis, and significantly challenged health systems. South Sudan had more challenges than all other countries, with an MCPR of less than 2, and total fertility rate of about 7, and of course LMIS was rudimentary. DRC had concentrated epidemic with over 70% of cases in Kinshasa, and no COVID cases reported in some of the regions, as at that time when the study was done. And all countries are highly donor dependent for contraceptives. So the trends observed in family planning utilization before and after COVID, I'll pick by country. And remember, we said we had individual assessments done by each country. And so the data collection differed on what was available in each country. So it's, even though we had a standardized checklist, it was difficult to get all the data from all the countries. As you can see, for example, in a Burundi, for new users, this was the trend between 2017 to 2019, there was an increase and then a decrease with only an increase. I mean, not much change in 2020. You can see all the data between 2019 and 2020. There was already a reduction in services and in uptake. And for revisits, it's about the same thing. You can see between 2019 and 2020, lots of negative reports there on both new users and revisits. For DRC, you can see the percentage change. As the previous speaker, there wasn't that dramatic change that we expected, although there was some decrease with some methods like IUCD insertion, like JADEL insertion, you know, the ones that really required skilled professionals. In Kenya, they looked at the projected uptake versus the actual. So again, we in Kenya decided to focus on adolescent uptake. This chart here is the projected uptake, you know, from, I mean, this is what happened. And if you see the actual reality, there was a dip, but not that significant, you know. So this was also surprising to us. The exception in Kenya was the hotspots. And the hotspots were the coastal area, Kilifi, Mombasa, Nairobi, and Kwale. And this is where there was, if you compare the hotspots and all of Kenya overall, you would see that there was some reduction in uptake of services, except for DMPASC, I think maybe because it was an injectable. And we didn't have data for all IUCD removals. So there was some difference within the hotspots, but not that great as well. In South Sudan, what we found was actually an increase in uptake of services, great increase in, you know, during the 3 quarters of COVID. And we think it could be because of the newly introduced data collection systems that happened in 2019, that maybe there wasn't proper reporting before then, but we don't know what led to this, but the data actually showed that there was an update in uptake of family planning during COVID versus before then. In Uganda, increase in uptake of services, interestingly, because if you look at 2019 and 2020, and so there was actually increase across all the 3 quarters of 2020 as compared with the previous year. In Zambia, similar findings. There was a drop, but this drop already happened, I would say, even before COVID. If you can see, there was a drop. But if you look, there wasn't that much difference between Q3 of 2019 and Q3 of 2020. Same percentage. So then we looked at the trends, you know, of CYP, and over the months, the trend showed linear increase. And although this was observed even in previous years, there was a little decrease, particularly between March and April. I think when the lockdowns were actually higher, people didn't know what to do, except in Kinshasa, in DRC. And one of the trends we also found was that there was less uptake of services in urban areas where lockdowns were more hard than in rural areas where people were more free. I think this is the trend that has also been observed by other researchers. So again, in Uganda, actually, if you look at all the methods combined, look at that increase compared to 2019. So again, surprising findings that we did not expect. For last mile assurance, we found that most countries, except perhaps 2 in the region, did do the last mile assurance processes as expected. There were definitely capacity challenges that were experienced. Again, there was not data that was captured by DHIS2. Risk assessments were submitted on time. Spot checks were due only after the study period. Study period was only up to September, and most of the assessments were to be done in October anyway, and so only a couple of countries did not do it. There was no significant commodity shortage, apart from Burundi, which had threatened shortages, but really not anything as significant. So one thing, of course, again, as the previous speaker, COVID-19 did not have a significant negative impact on service utilization or delivery of contraceptives to the last mile, except in Burundi and DRC. While in Kenya, it was mostly in those hotspots. And in Uganda, there was some decrease in dispensing of contraceptives, which we did not talk about all the interventions that were done, all the innovations that helped to, maybe mitigate this. Service delivery visits in South Sudan and Uganda actually increased, and then in Zambia, there was a small dip in public service utilization, but increase in private sector and faith-based facilities. Lessons learned from this study is when doing a multi-country study or research, it's important to have uniformity and standardization in the research. And we believe that UNFP is working with government and doing like 2 to 3 year procurement plans and actually procuring ahead of time might have helped to mitigate some of this availability of our contraceptives. And countries have different data collection systems, and individually, ability of the countries to collect data, service disaggregation, age groups differ. Some countries had all the data and some countries did not. So again, in conclusion, like I've said, we didn't see any great, affection of either supplies or of either services or supplies, even in countries where there were lockdowns. We should anticipate future similar events, hopefully not, but they could come, other pandemics. And it's very important to have in place interagency, multi-sectoral business continuity plans, particularly in these days of climate change. All the floods happening globally, all the wars coming up that you don't plan for. But we must make sure that we have continuity plans and that there's public-private partnership. We should look at telemedicine, provision of services just beyond in-person contact, and also really look at long-acting reversible contraceptives, as the backbone for service provision and multi-month dispensing of commodities. And then realign community health services. This morning I was at a session where we're all talking about community-based services, community-based distribution, and it's really, really important to realign community health services as part of business continuity plans during times of health emergencies. Of course, I've talked about enhancing non-digital spaces for service provision and information, outreach services, and follow-up of clients. And then additional research is really important, and I think more research has also been done to see how potential disruptions can be averted for other pandemics we don't hope for, but which might happen. And then standardization of family planning data collecting systems, especially in countries that have, that are in humanitarian settings. Thank you. That's the end of my presentation.
I'm glad we had mostly the same findings, but a few were different, and I'm very curious about those.
Oops, that's the wrong one. Is this?
Yeah, it's hard to get everything.
Is this your present? Do you want to just go? Oh.
I can go.
Oh, you're doing it for me. Okay, great, perfect. All right, thank you. So yes, well, I can go through my presentation really quickly because everybody else set the stage and gave the background. So let's see. So I don't need to explain the rationale for this study, but what I did want to say is that I'm presenting on behalf of Avenir Health. The National Composite Index of Family Planning was implemented by Track 20, Avenir Health, but you already heard their work, so I don't need to introduce that also. And so we thought that the National Composite Index for Family Planning would be a really good opportunity to look at across multiple countries what the effect was of COVID on family planning programs, and that this NCIFP offered a really good opportunity to look at this. So the NCIFP was started after 2012, and it was really to look at, for FP 2020 and now FP 2030, the sort of the types and range of family planning, the policy environment and programmatic indicators and rights-based programming of family planning. So that there are 41 items across 5 dimensions that look at the strength of the family planning program. And in 2021, we said this is a great opportunity to add some supplemental questions on COVID to look at the responses related to COVID. So the NCIFP looks at 5 dimensions. It looks at strategy. Does the government have a strategy? Is there support for family planning? Are data collected and are data used? Look at quality. Are services up to, sort of WHO standards? Is equity addressed in programs, looking at sort of marginalized groups and making sure that everybody has access? Accountability when there are issues in programs, are there accountability mechanisms? And finally, the supplement, which I'm going to be talking about now. So there have been 3 rounds of the NCIFP, 2014, 2017, and then in 2021. And you can see that the numbers of respondents or countries in 2021 was lower. And of course, this was because of, the COVID, but also the war in Ukraine. That region of the world have many less, fewer countries. And the methodology is talk to about 10 to 15 people who know the program well in that country. And for the first time in 2021, this was done with an online survey, but somebody could get a paper questionnaire if they wanted to. And then the data were analyzed in Excel. So what I want to talk about really quickly, just to give you a flavor for it, is the dimensions scores for 2021, and then go to the COVID supplement, and then some open-ended questions. So just to let you know, the overall scores for these dimensions was a total of 56 out of a potential 100%. So you can see that there's still quite a ways to go just to improve family planning programs. And you could see that equity was the highest scoring and accountability was the lowest. But let me quickly go on to the COVID supplement questions. We asked 4 main questions in 2021, but you can see we added a lot of different dimensions into one of them. But basically to look at how did COVID affect a country's ability for financing, advocacy, community mobilization, supply of contraceptives, record keeping, data use, restrictions on movements, and then also looked at access to short-term methods and long-term methods. It looked at government commitment. Did that waver with COVID? And then was the program able to maintain availability of, again, short-term methods and long-term methods? And then the extent to which clients were able to access the counseling and methods during lockdowns. So this just shows you the scores by each of the dimensions plus the COVID supplement. And you can see, so in looking at this, a high score, and you can look at the black bar at the right, a high score means there was little impact of COVID, and a low score means there was more impact of COVID. So you can see that it was about a little bit less than 50%. So it means that there was an impact. The respondents perceived that there really was an impact of COVID on various aspects of the program. You can see that the Sub-Saharan Africa, Francophone Sub-Saharan Africa had the least impact of COVID, and Latin America and the Caribbean had the most perceived impact of COVID. So if you look at this spider graph, you can see that this looks at there were regional variations in the impact of COVID. The least, this is just all of the mapping of all the different COVID questions. The least impact was on government commitments. Governments still maintain their commitment to family planning. And maybe not surprisingly, the most impact was on advocacy and the ability to do community mobilization. There was also, it's interesting from the other presentations, people perceived that there was actually less impact on availability of short-term methods than long-term methods. So I'm curious to sort of look at those data. And you can see the green, again, the green lines were Francophone Sub-Saharan Africa. So you can see that that was where there was least effect. This is hard to quite decipher right now, but what we did is we looked at some of the components of the actual NCIFP that were related to the COVID questions to see if there was sort of a correspondence between what people said in one section of the NCIFP plus with the COVID questions. And you can see that there's quite a bit of variation. That Asia had the biggest, showed the biggest increase in these dimensions between 2017 and 2021. And they were the Francophone, Sub-Saharan Africa Francophone countries saw the least impact of COVID, and Asia saw the second least impact of COVID. So that probably explains some of this. People perceived that there was more of an impact on finances than actually they all responded in another section of the questionnaire. And again, the data about availability of short-term methods and long-term methods was the same between the perception of COVID impact and people's responses. There were some open-ended questions, and you can see what fear of COVID, travel restrictions, halting of services, we heard about that in other travel restrictions, so that people did mention some of the specific ones. So in the interest of time, I'm just going to skip over that one. It was just summarizing what I'd said, but we're hoping that, these are data from 69 countries. So this is a sort of a bit of a unique data set to look at COVID. And we hope that these data, when triangulated with other data like we've heard in this session and we'll hear, will just help really give us a better picture of how COVID has affected family planning. So thank you.
Okay, so I'll be much quick because of time. I'll be presenting on the impacts of COVID-19 pandemic on sexual and reproductive health in general, but then of course give a deep dive to family planning as I even talk about the others. And of course we went to 5 countries, which included Burkina Faso, Ethiopia, Kenya, Malawi, and Uganda. The selection of these countries was quite purposive because these are countries that we had access to, either directly or that we had partners that were working in those specific countries. Of course, everyone has really given a good background on how COVID exerted devastating pressure on health systems. And of course, as a result, there was response by governments to COVID-19, which were largely broad and at times non-specific. And of course, some of these measures or interventions diminished access and utilization of services, of course, to different extents. And in most cases, the most vulnerable in our societies were adversely affected. And of course, to date, data is still being generated or analyzed to try and give a complete story. But as at the time we were conducting the study, really, there was limited data that could tell how much COVID has affected access to sexual and reproductive health. And therefore, we aimed to assess the impacts of COVID-19 pandemic on the availability, utilization, and access of sexual and reproductive health in the 5 countries I've mentioned. In terms of methodology, we utilized a mixed a cross-sectional study, of course, with a mixed approach to data collection. We had both quantitative and qualitative approaches to data collection. And in terms of quantitative, we talked to close to 3,473 women across these 5 countries, and also 466 health providers. Qualitatively, we also attempted to interview some women and girls, healthcare providers, within the facilities. And then we also talked to representatives from the civil society organizations and even policymakers in these countries. The data collection was between January and May, and this is important because it tells us the timing of this particular data. We know that COVID-19 now has been in existence for more than 2 years, and throughout this period, there has been really variations in intensity, response, and so on and so forth. Now, so in terms of key findings, I'll spare you the socio-demographic characteristics and jump straight away to what we saw in terms of access. When we asked women where they were getting information around their needs on sexual and reproductive health, of course, majority of women indicated that they were getting the information from friends as well as from the internet, which opened an interesting conversation on the role of social networks as well as internet platforms in terms of access to information. I think that has sort of catapulted the debate around telemedicine and how social media platforms can be leveraged to improve access to sexual and reproductive health services. When we looked at family planning, again, for for all the women that we are including in the study across the 5 countries, of the women that required or needed contraceptives, as at the time of the study, about 26 or 1 in 4 indicated that they needed but could not receive. And then on the right, we also show the differences by country, and we see that Burkina Faso had the highest proportion of women who needed contraceptives, but at the time of the study could not be able to access, followed by Kenya, Uganda, and Ethiopia. Of course, these differences are modulated by either the ongoing interventions at the time of the study, and also how response to COVID was different across the 5 countries that were included. Now, of course, down there, we also show that of those that needed contraceptives, again, a majority of them were able to receive short-acting contraceptives. I think that's a narrative that is common based on the presentations by my colleagues earlier on, and just about 1 in 3 were able to receive long-acting reversible contraceptives. Of course, something else not reported here is that there was a significant method switch, either women moving from long-term to short-term, or more preferred to less preferred methods of family planning, which of course then has implications in terms of continuity and even the ability to remain adherent to their methods. Then of course in terms of barriers, there'd be no need to emphasize, but of course restriction in movement was one of the key main barrier to access to FP and other SRHR services, as noted by those women in Uganda as well as in Kenya, who the lockdown really affected them. Then how did these women respond to all these barriers that were affecting their access to family planning and contraceptive services? A huge proportion really delayed seeking the service. And of course, we very well understand what it means to delay seeking family planning. About 1 in 4 also visited another facility. Of course, either another facility or another health provider. These also included seeking service, let's say, from a pharmacy or another private provider, which of course would have implications to cost, which means that only women who could afford were able to at least meet their needs at that particular time. However, unfortunately, 16% decided not to visit any provider as reported. Of course, availability has been reported as well. There were stockouts, and what is important to note here is that stockouts also varied across the duration of the pandemic, either based on earlier on we saw the impact was higher, when those supply chains are broken, but then over time, I think the resilience of the health system kicked in and the stockout issue was addressed. Again, in terms of utilization, we saw a general decline in uptake to most services, not only contraceptives, but also antenatal care, maternal, and child care services, and so on and so forth. And of course, some of the reasons, as explained by the clients we interviewed, were that there was fear around COVID, hospitals were seen as hotspots, and so on and so forth. Then facilities also responded quite interestingly to try and adjust their service provision to mitigate either the issues brought about by COVID. And interestingly, referral patterns were altered by almost 1/3 of health facilities that we talked to, about 1/3 also altered the timings of service. So to make sure that there were sustained services, some then said, you know what, we'll still allow patients to come, but only on Friday. And then interestingly, again, there is a debate that has increased now, the introduction of self-care as really a core component of ensuring that services was accessible during the COVID-19 pandemic, and also telemedicine, but mostly in Kenya. And I've shown the country differences on the right side of that slide to show that, well, these approaches were embraced by facilities. It was not widespread across each and every country. We see that Kenya really took up telemedicine and self-care more strongly. Recommendations, I think this align with what has been said before. There's definite need to strengthen community health outreach and delivery systems to make sure that we can mitigate some of the shocks that would come about by a large-scale pandemic such as COVID. And then, of course, just effort to strengthen the health systems. At the policy level, what is important is that there's need for multi-sectoral approach in terms of coming up and implementing both the development and implementation of pandemic-related policies, and a continuous review really to make sure that we are adjusting these policies to the realities and trends and challenges. Then, of course, service delivery to ensure that we have maximum access to services. We need to leverage on the potential of telemedicine and self-care to make sure that even when we have barriers, that women can still access the services. Thank you very much.
Thank you very much for the very wonderful presentations. I think it's now time for us to open it for comments or questions. I did want to follow up on the point that Karen made about the fact that there were changes in terms of access to long-acting contraceptives rather than the short-acting contraceptive. I think that message came from Jerry and also came from Ramatu. But when Kenneth was presenting, I think I saw something like a switch. For Kenneth, we saw where there was a movement towards short-acting contraceptives and a reduction in long-acting contraceptives. But from Ramatu and Jerry, we saw that the movement was towards long-lasting contraceptives. So when you come over here to, or when you want to respond to the comments that will come from here, please try and touch on those two important points. But also for Ramatu, I think you spoke about visits to the facilities. I wanted to also, I think you want to touch on whether visit translated to assessing of care. Were they able to assess care when they got to the facility, or you use their visits to the facility as the main indicator? All right, that's for you to consider when you come to when you respond to the comments that will come. But I now open it up. Is there anyone with comments or questions? Okay. All right, thank you very much. There's a microphone just by your side.
Okay. I'd like to thank the presenters. Eugene Konyo, the UNFPA representative in DRC. The presentation, I think there is one common thing that came up, that COVID affected family planning, but not to the level that was expected. It came across in all the presentation, and there are wide variations. So my question goes to the first presenter. You mentioned the changes between 2019 and 2020. I was wondering whether, do you think there could have been a difference if you look at 2018 and back to see whether there is a trend, whether the increase in 2020 was not that much as it ought to have increased. For example, if there were no COVID, because you compared on the two years, and it could have been maybe I'm just wondering whether it could have been better to see the trend by looking backward. Thank you.
Thank you very much. Any other person? The lady.
Thank you, everyone, for your nice presentation. My name is Christine Laswai, Senior Technical Advisor for Family Planning RH with the Momentum Integrated Health Resilience Project. Kenneth, thank you so much for presenting the coping strategies. I think that we've seen this data in terms of temporary, like a temporary decline and then a bounce back that demonstrate baseline resilience in many of the countries. I was just wondering about the data that the other three presenters shared. My hypothesis is that the reason why we're not seeing maybe sorry, let me just take this out. Maybe a considerable decline in use is because there's already strong baseline resilience. And because there is coping strategies, then it shows very much in the WHO Pulse surveys. So there are many facilities and individuals that were already undertaking these coping strategies. Now, the coping strategies vary from different countries. So I was wondering to what extent you are controlling for the different countries, especially fragility. Countries that are more fragile than others. I was happy to see South Sudan, but I'm not sure about that data because of what you talked about, the HMIS system. Similarly for the index, you know, to what extent you've been able to disaggregate between the, fragile settings and the less fragile, because my hypothesis again is that there could be less bounce back in those countries as well. Thank you.
All right, thank you. You have a question? Please, could we keep the question sharp and straight? We are running a little short on time.
Sure, mine relates a little closely to the previous one. Thank you for these presentations. It's really wonderful to see the resilience of family planning programs. We haven't seen that in other programs during COVID-19, like immunization. And I wonder if during your studies you have any reflections on what particularly makes family planning programs more resilient than some other health programs. Thank you.
All right, I think, okay, that's that question, and then we come to the presenters to respond.
Thank you to all the presenters. Mine is not a question, but a comment. I happened to be in South Sudan at that point. I was the rep for UNFPA in South Sudan. So we also asked, what was happening in terms of the use in family planning, because family planning use is so low in South Sudan. But we saw a rise during this time. And what happened was that because women were not coming to the facilities to deliver for, postpartum family planning, because even deliveries are 11% at health facilities, 11. So most of them don't come for you to have an opportunity to provide the information. But during this time, midwives went out to the communities to give women information and provided information on family planning, and they were taking it up because nobody had ever reached to them. Demand creation was almost non-existent. Nobody was reaching out to them. So that speaks to the demand creation and community-based approaches that we must really emphasize in such context. So that is one point. For Uganda, again, I'm now in Uganda. So I'm now in Uganda, but what our staff told us at the border, the initiatives you're talking about, the border initiative really did something that is, unprecedented. They went out dishing out condoms and pills and information, and they are still being used up to this date. So innovation also worked. Just wanted to share those. But I also wanted to comment quickly on stockouts. The last presenter talked about stockouts during COVID, and wondering, were there really stockouts in the country, or they were just not in those facilities? Because there shouldn't be stockouts during that, in that short period, based on what we procure at UNFPA with other partners. So that is of concern to us. There shouldn't be. Maybe they were just not available and they were in other places, or they couldn't be distributed where they should have been. Thank you.
Thank you very much. Each person, I mean, you have questions that are directed to you, but Karen, there was something I missed, I wanted to touch, but I missed about your presentation. It was on the question of accountability. Accountability was way lower than, I think, than every other indicator that you used. While I was surprised to see that equity was higher than most, and I was surprised about that, especially in terms of rural-urban dichotomy and other such. But let's start from Jerry, then to Ramatu, and cross over to the other bench. All right, let's do it, maybe 2 minutes each.
Yeah, thank you very much. I'm just going to work my way through the questions. So the first question was about, the fact that we only looked at 2 years of data, 2019 and 2020. And I think it's an excellent question. Would the data have been different if we had gone backwards to 2018, 2017, et cetera? I don't think so. So, as part of Track 20, we work in many of these countries, and we've been working there since 2012. So in most of these countries, we have a good sense of what their rate of growth is year upon year in those countries. So some places like Mozambique, have or Burkina Faso, they have a really fast rate of growth, 2% or 3% a year in terms of number of users and MCPR and things like that. And that's really excellent. Some countries have a much lower rate of growth, but it's consistent. And so I think, in the example of DRC, we know that their program grows around 0.5% a year. And that's where most of our countries are sort of in that 0.5% to 1% range. So I don't think adding previous years before 2019 would have made a big difference. One of the reasons why we didn't is that we use service statistics data. And Track 20, one of our major goals is to improve the quality of service statistics data and get it to the point where it is of a high enough quality to be considered useful. And so, we had 15 countries in this study. Not all those 15 countries had service statistics that were considered a high enough quality to be used in 2018, 17, 16, et cetera. So in order to be able to use all the 15 countries that we had selected, we had to use the first year that they all had data at a sufficient quality level, and that's why we went with 2019. Should I answer the other questions? Or, so I think, the next question was about sort of resilience and fragile countries. I think a lot of it depends on what specific country you're thinking of. I was looking through here and what my definition of a fragile country would be. I'm looking at a place like Niger or DRC. Niger has a really low MCPR, I think under 10%. DRC is another country that's very politically unstable, where we have huge gaps in services, outside of the major cities, things like that. And in both of those countries, we actually saw growth year over year in implants and injectables in those two countries. So, I think that there's definitely funding issues. I think it definitely boils down to which countries you're interested in. I'm sure that if there are conflicts, I'm sure if there are political crises, that can play a role. But my sense is that, as long as the data, we see the same trend in 2019 and 2020, for the fragile countries that we have on this list, I think that they seem to be holding up pretty well. And then for the third question about why family planning programs are resilient, I have a couple thoughts on that. So one, I think, is that, long-term methods have become a really popular thing and are being promoted really heavily. And so because of that, there really was no need for those women to stop using. So a lot of women got an IUD in 2017 or 2018. And so when COVID hit, there was no need for them to get a new implant or IUD for at least 2 years after that. So they were able to sort of wait out the lockdowns and things like that to avoid that. And those women continue to be counted as users year on year. So they factor into the overall health of the program. The other side of that, I think we also saw that short-term methods, for the most part, are relatively easily distributed. So we were seeing, I think it was in Philippines, that they were doing food delivery services paired with the delivery of oral contraceptives. And in Togo, they were giving out 9-month supplies of pills instead of the usual 3-month. So I think one of the benefits of the family planning program is that there are relatively easy ways to make modifications where, an immunization campaign always involves face-to-face contact with somebody with a vaccine in their hand, and that makes it more challenging.
Thank you very much.
Thank you for the questions. I think Mary has helped answer some of the questions.
Yes, definitely.
But about the revisits, it's really looking at, like, I have like tons and tons of slides, but can't show all of them. It's really looking at the trend. We looked at trends from 2017 to 2019, and then what is happening all quarter 1 to 3 for all of the years. And so it's really looking what happened in those previous years versus what happened, you know. And like Jeremy said, a lot of the uptake, you know, if you have an injection, I mean, if you have an implant or an IUD, you're not likely to have a revisit within 9 months. But where they did need to have a revisit, when they came for the first time, they got like 3 to 6 months worth of supplies, or 3 months worth of supplies. And then all the interventions, the borders and everything, they got delivered to them. I think that is a lot of what helped. And I hope that really countries have learned from all this to see that there's really no need for women to come all the time to the hospital, and the community-based initiatives were great. So the issue of resilience, again, based on UNFP, is work with governments, like I mentioned. We quantify, we procure ahead of time. So as at the time the pandemic hit, we had already placed orders for contraceptives like the year before, for that year. So they did arrive on time before all the supply chain issues, you know, kicked in. Again, our work was just for quarter 1 to 3 of 2020. So a lot might have happened afterwards, of course, funding cuts, etc. But at that time, even with the funding cuts, we really didn't suffer that much of stockouts or lack of availability to services. I think that's all that I have.
All right, thank you, Ramatu. Then over to Kari.
Yeah, I think we'll do the same. Some of the questions I think have been
Have been answered.
well answered, and thank you for the question about fragile states. We're still analyzing these data, so that that's a good thing for us to look at with the COVID supplement. And I meant to say that the report of the NCIFP 2021 is available on Avenir Health's Track 20 website, and including the data. So you can, if for your own country, the countries you're interested in, you can actually get the data. So yeah, please do that. And I'm wondering, discontinuation. I mean, we have put such emphasis on, you know, on discontinuation, and I suspect what happened is, I'm wondering, I haven't seen any data on it, but I wonder if discontinuation went down again because people said, well, I might not like this IUD, but I better keep it now because. so anyway, that's just another speculation, but.
Thank you very much. I think I totally agree that a majority of the questions have been answered quite well. I'll just comment on the short-acting versus long-acting data. I think perhaps it reflects some of the things that are happening within the countries. In some countries, from the onset of COVID, there were guidelines that were provided by ministries of health that, you know, encouraged providers to prefer methods that sort of limit person-to-person interactions, as well as methods that would make women not come back to the facility frequently. So I think that played a role in the patterns we see, but also at the same time, it also intersected with the preferences of these women, you know, whether they wanted methods that they could easily do away with, if their fertility preferences changed, and so on and so forth. So the data we present is really as reported by women, the methods that they were given at the facility, but that reflects the subset of women that we interviewed at that particular phase of the pandemic. It may not entirely show the overall picture over the pandemic period. And then finally, I think on stockouts, again, our data sort of reflects that temporal pattern with stockouts. Definitely, some of the supplies are within the country, but of course, there were variations in supply chain interruptions that at times on the day of your survey, as you're asking the question, do you have this particular supply today? they'll tell you no. But last week we had, so of course that's what we present in the data. Thank you.
All right, thank you very much. I'm sorry that we had to take a few minutes of our, like 3 minutes of our allotted time. I really thank you. Thank you to Kenneth, Karen, Ramatu, and Jerry. Thank you very much for coming to listen and for interacting. Can we, okay, yeah. Thank you very much.